So why would an insurance company take part in the example that we presented previously in part one? Well, because they know the population and they can predict the number of claims and they can price the insurance, the policy accordingly, so they can make a profit. And the numbers are, fairly simple, right? Say that if they sell insurance to 1,000 individuals that are facing basically the same conditions, right? Again, think about COVID-19, right? They know those 1,000 individuals, they all face, on average, the same risk, even though they face different risks, right? In reality, right? Some of them are more exposed than others. But on average, they face about the same amount of risk, which is going to be 4%. Well, then they know that 40 of them, out of 1,000, 40 of them are going to be ill, and they know that 40 of them are going to lose the $50,000 in income. So they know that if they fall ill, the insurance company is going to have to pay them $50,000. So it's going to cost them $2 million in claims. So the numbers are pretty easy, right? To break even, all this carrier needs to do is to charge $2,000 per individual. If they do that, if they charge $2,000 per individual for all 1,000, they will have $2 million, which is enough to pay for the expected claims. If they charge any more than that, which they will, obviously, that's all profit, right? So any amount over 2,000, they can make a profit. So there you have it. All they have to do is charge more than 2,000 and they'll make a profit. So everyone is happy. People are insured, people are protected. None of these people are going to lose $50,000, and the insurance company makes a profit. So when an insurance company quotes the premium, that premium needs to include the break-even point, right, which is going to cover the losses, because they need to cover, the insurance company needs to cover the losses. They're not in business to lose money, although I could tell you some stories about that. Then it has to add some kind of admin cost because it's expensive to, issue the policies, all the employees, all of that stuff. Okay, you put that in there, and then you add the profit to it, to the premium, and that's going to be the quote that you send to the individuals, and that's going to be the premium that they're going to pay. Now, if you go back to the chart before, you will notice that the most anyone is willing to pay will be 5,000, which is the difference between the possible outcomes. Is 5,000. So the insurance company knows that. So they know that they will break even at 2,000. Actually, that's not true because I didn't include the admin cost, but just for the claims, you will break even at 2,000 per customer, but they're willing to pay up to 5,000, right? So as long as you don't go over 5,000, you can make a lot of money in this market. So what happens when you introduce health insurance in the health market? Well, unfortunately, there are a lot of great things that happen, but one of the bad things that happens is that you actually introduce what we call market failures, and we've seen them before. It's a significant issue because it's behind a lot of the problems that we have in our system. Our system, the way it is, relies completely on third-party payers. Third-party payers being insurance companies. 90, as I have here, 97% of all hospitalization is paid by an insurance company. Think about that, right? 97% of all the hospitalizations are paid by someone other than the individual. Someone else, the third party payer, the insurance company, is paying for that. And why is that significant? We're going to talk about that, but go back to chapter, whatever that was, 1, 2, maybe 3. Now we have a market where it seems like there's a single payer. Is that what I'm saying here? If 90% of all the hospitalizations are being paid by insurance companies, does that mean that we have some type of monopsony here? Well, not quite, but definitely very close to that. Maybe it's not a perfectly competitive market, right? Because you only have a few insurance companies making 97% of all the paying all 90% of all the claims. That's going to be an issue. Furthermore, more importantly, I would say that the problem with insurance is that it creates an incentive for overconsumption, which we've seen before when we looked at the demand, right? When individuals have insurance, when they're covered by insurance by a third party payer, they're going to tend to overconsume. In the very same way that when you have insurance for other things, you tend to take more chances. Okay, which is what we call moral hazard, which we mentioned before, and we're going to mention again later on. But the introduction of insurance has clearly increased the expenditures in healthcare, has increased overconsumption, and in some ways it has removed some of the incentives for providers to be more efficient in some cases. And that's because the insurance company is going to pay for the bill, so there's no incentive. But as we're going to see, that is actually not always true, because insurance companies do have ways to force the providers to be more efficient. Some of the biggest issues we have in health insurance are due to information, and these are we have them in three categories, which are consumer information problems, moral hazard, and adverse selection. Moral hazard here being the third or fourth time that I mentioned it, right? But basically what we're talking about is that, in particular in this market, which is not true about all markets, but it's not unique to this market. It is maybe true that this is possibly the only market where we have all of them combined at the same time. And that can be, I don't know, I would love to have a discussion about that. I'm sure we can come up with another market, but this is definitely a very special market, the healthcare market, where you have all the different types of problems. But what they are is, when we talk about information problems, is the unequal access to information, where the parties involved, and at this point we can say that the parties are going to be the providers, the third party, right, the carriers, the insurance companies, and the individuals, the patients. They don't share the same data. They don't have the same information. Some of them know something that the others don't. Each of them has special, unique information that the others don't. So we start with consumer information in general, very broadly, right? One of the problems with healthcare is that it's hard to understand. It is very time consuming to understand. You need to do all this research. And let's face it, people are not ready, capable, knowledgeable enough to process that information, right? I'm sure you've done it, because I've done it, and we all do it. When something happens, when you have a little pain, what do? WebMD. You go online and you research it, and you scare the heck out of yourself, right? Because oh my God, I think I have this. Well, don't do it, because you really don't know what you have. My wife does it. I try not to do it, and it's just something that you shouldn't do. You should just go and see your PCP, and the PCP will know better than you. But bottom line, right? For a market to be efficient, the consumers need to know how much they're paying and for what, and when and where. And that information is not that clear. It's better now than ever before. And I'm telling you now, again, because I work for Blue Cross Blue Shield, that this is something that I spend a lot of time in. We try our best to get more information to our members, to the patients, because we want them to know. We want them to make rational, smart decisions with their money and their health. And then there's moral hazard. Okay, so now finally we are moral hazard. It has mentioned before. So what is moral hazard? Well, moral hazard is a situation where there's an opportunity created to gain from acting in a different way than what the others would expect you. Okay? The others expect you to behave this way, but you actually can gain from not behaving that way. And healthcare is a great example. But I'll start by giving you another example, right? For example, seat belts. The seat belt on your car has created a moral hazard. Why is that? Well, because when we made seat belts mandatory, basically because the insurance companies lobby for that, right? Because insurance companies saw the opportunity, like, wow, if everyone wears a seat belt, claims will be lower because people will be more protected. Yes, that is actually true in principle, but not in the reality is that now that people are protected, or they have the false feel that they have the false idea that they are protected, they're going to incur in activities and situations with higher risk, meaning they're going to speed, they're going to go faster, they're going to be doing things while driving that they shouldn't be doing. Why? Because they feel protected, they feel insured in some way. Okay, so when you insure someone, when you protect someone, that someone is going to act differently. Go back to the very first chapter when we talk about the AIDS epidemic and some of the things that we did back then, and they ended up causing potentially more harm than benefit. This is what keeps insurance companies awake at night. Okay, this is what keeps us awake. Because we need to figure out how to fix that. That is a big problem when we insure. Think about when you get that insurance. I always love when I buy an electronic and they say, oh, for another $30, your laptop is going to be covered. You can throw your laptop in a body of water. You can drop a screwdriver. I always say that. Drop a screwdriver on your laptop. Like, why would I have screwdrivers flying around my laptop? I don't understand where they come from. But you can drop a screwdriver onto your screen and it will be covered. Well, let me tell you something. If I buy that, which I never do, I absolutely never buy that extra insurance or coverage. If I ever buy that, trust me, I'm going to be putting screwdrivers through my screen. And I'll probably be doing other stupid things, that will involve water, fire, and God only knows what else. Right? Because I'm protected. What do I care? I'll take more chances. Okay? So, keep in mind that the moral hazard, as you look at things like the AIDS epidemic, as you look at the COVID-19 epidemic, and others. And finally, adverse selection. Adverse selection is the situation where the people that want insurance are the people that probably shouldn't get insurance, right? Because think about it in simple terms, right? If someone, imagine you have an insurance company. Let me give you okay, I'm going to come up with this on the fly. Imagine you own a little insurance company and someone comes in and says, hi, yes, I would like to purchase insurance. Yeah, sure. What for? I want to purchase insurance in case my microwave falls on my head. Well, that's interesting. Why would you think that the microwave is going to fall on your head? No reason, I don't know. I just want to make sure that in case that ever happens. Clearly, that's a person you shouldn't sell insurance to, right? Because a person that comes to you asking for something like that, it's someone that apparently knows something about themselves that you don't know. Okay, what we call this is asymmetric information. They know something that you don't know, and that's why they want insurance. Now, healthcare is a little more complicated than that, because there are many more possible scenarios, right? I want healthcare because I don't really know. I don't know what's going to happen to me. I don't know about whether or not I'm going to be ill, etc. But there is such thing as adverse selection in health insurance. And the best place where you can see it in insurance is if you have two insurance products, and one has a richer benefits. It covers for more. You have lower co-payments, a lower deductible. You are going to end up having the people that know that they're going to be sick for whatever reason. They're all going to end up in that product. And if you sell at the same time a product that doesn't cover much, it's very cheap. It's a very cheap product, but it only covers catastrophic things. It has very high deductibles. All the healthy people that they know they take care of themselves and nothing's going to happen to them, they're going to end up there. That's where you see adverse selection in clearly you see adverse selection in health insurance. And that is why in insurance, we play with the premiums. We have different rates for different populations and different products, and etc. Because we know that people pick their plan based on that information that they have about themselves that we don't have. For example, another very common example is if you know that you or your spouse or whatever, or your partner, if you know you're going to become pregnant in the next year or so, you definitely want to get a better healthcare plan, right? A better healthcare insurance, right? Because you know you're going to use it. So if you're going to use it, you might as well get something better and reap the benefits of that better coverage. And then after you have the baby and all of that, and once you go back to your previous health status, then you can just drop that coverage and go back to a cheaper coverage with with not as rich benefits, because you know that you don't need it. You're hoping that you won't need it, I should say. And that's how insurance companies, of course, we get around that, or we try to modify that with deductibles, with co-insurance, and as I mentioned before, by tweaking the rates. So our underwriters, they tweak the rates to make sure that if you pick a richer plan, you're actually paying a higher rate to compensate for the risk that we believe you're bringing to the pool. Okay, so we do take care of that. And in some cases, we refuse to insure altogether based on our medical policy, which is driven by our panel of doctors who look into all these treatments and illness, and they decide what is appropriate care in every case. If it existed, what would a optimal insurance policy look like? Well, it will definitely be an insurance that make sure that there is a balance between the risk and the imperfect information, right? So it prices accordingly between these two, the benefits and the imperfect information. It would be the type of insurance that makes people accountable for their actions and make sure that the cover individuals, the policy holders, are taking care of themselves and they're not incurring in extra risks. Right? It will require very high deductibles and large co-pays to get around all of the issues, all the market failures that I mentioned before, all the information related issues that we've covered. It will be a plan that segregates people based on health status. You will want, so imagine you take the population and you divide them in 10 groups, right? The first group will be absolutely super healthy, super young. We expect no claims. And then the top, the number 10, right? 10 buckets. The 10 will be people that already have these illnesses, people that already have conditions, people that are going to have high claims. Okay, so in a perfect optimal insurance plan, you would pull them accordingly by their health status, so you could charge them the appropriate and fair rate to each of them, so you don't have healthy people paying more than what they should, and you would have those with illnesses will have to pay an appropriate amount so others don't have to pay for their illness. That would be an optimal insurance plan. Don't confuse that with your optimal social plan or optimal whatever you want to call it. I'm talking about insurance. From an insurance point of view, that is what would be optimal. Bottom line, an optimal insurance plan will be a plan that would only cover for those things that you will cover that you would pay for if you didn't have insurance. Okay? If you self-insure. An optimal insurance plan shouldn't pay for things that you yourself wouldn't pay for if you had to pay out of your own pocket. That would be the perfect insurance. And I have some notes on insurance that I want to add because they were mentioned before, is this idea of insure versus self-insure. And I want to make sure that you understand it because it's one of the big eye-openers when I have conversations with people. So when it comes to private insurance, you have two types of employers, clients, accounts. You have the insurer, and then you have the self-insure. Okay, the insure is what most people understand for insurance. Something happens to you, whatever it is, an illness, an injury, and the insurance company pays for it. There could be deductibles, there could be copay, that's fine, nothing to worry about that. That has nothing to do with it. But the insurance company will get the bill from the hospital. The insurance company will pay for that bill because the insurance company bears the risk. Now, with an ASO, a self-insure account, that is not the case. With a self-insure account, an employer, when the employer contracts with the insurance company, the insurance company is not responsible for the claims. So let me explain how the process works. Say that an employer contracts with Blue Cross Blue Shield of Massachusetts, for example, under a self-insured contract. Okay. Now, someone that works for that company goes and gets a appendectomy. I don't know, whatever, and it's $50,000. The hospital is going to bill Blue Cross Blue Shield for $50,000 because Blue Cross Blue Shield is the carrier. Right? We are, Blue Cross Blue Shield is on that little blue card. Okay, Blue Cross Blue Shield pays the hospital the $50,000, and the hospital is happy and goes away. However, because this is a self-insured contract, Blue Cross Blue Shield is going to turn around and bill the account for the $50,000. The account is going to pay for the $50,000, not Blue Cross Blue Shield. Blue Cross Blue Shield, all it's doing is administrating the bills. It's just processing, just making sure that everything is fine, making sure that there's a network, they print the blue cards, they do all the things that you need to run insurance except paying the bills. The insurance bears the account bears all the risk, all of it. This is something that, in general, only companies with more than 500 employees have. Think about the risk that you bear as an account, as an employer, under a self-insure agreement. Say that you are, let's make it extreme. Let's say that you're a small business with 5 employees and you're self-insure, and one of them gets cancer. You could be looking at hundreds of thousands of dollars for many years in bills. That will bankrupt you. You will not be able to pay for that, and you will go out of business. So this is reserved for larger companies. And why would they do that? Why would a company do something so crazy? Well, remember the premium calculation that we did, where we calculated the expected claims plus the admin cost plus the profit? Well, if the pool is big enough, and when you're a large employer, the pool can be big enough, right? It could be 1,000, 10,000, 20,000, 50,000, 60,000, 90,000 employees. We have accounts that have 90,000 employees. then in that case, you can play insurance. You can become an insurance company, and the profit that the insurance company gets to keep is now yours, because you have a big enough population that you can play insurance. Okay, so that's why we have self-insure accounts. Another comment that I want to make is that the public usually doesn't understand the premiums. There is the employer premium, and then there's the employee premium. Okay, when an employer contracts with a carrier, they pay. They being the account, the employer pays for a portion, and then the member pays for another portion. On average, in the United States, the employee only pays for 20 to 30% of the total premium. The employer pays for the other 70%. So when you get your paycheck, right, and it says whatever amount of money, and you see that, I don't know, $100 was taken out of your account to pay for health insurance, that doesn't mean that you pay for all of it. You only pay for 20%, 20 to 30%. Your employer paid for the rest. So it's kind of like you have a higher wages than you actually think, because the employer is subsidizing your healthcare plan, and that varies significantly across the sizes of companies, across geographically, locations, and even industries. One of the things that ACA did, the Affordable Care Act did, is that it prohibits the carriers from selling in the exchanges using risk pooling, where they can discriminate and they can segregate. They can have healthy individuals in one group and others in a different group, and then rate accordingly. They're not allowed to do that. They have to put everyone in the same pool, what we call a heterogeneous risk pooling. That is the reason why the premiums are so high, because insurance companies had to price accordingly, and that is also the reason why so many carriers stopped quoting in the exchanges, and many other things. There are certain things that I shouldn't say, but ways to. Let's put it this way: there are many ways that insurance companies have stayed away from exchanges, and there are many ways insurance companies try to make themselves not very competitive in exchanges because they don't want the bad risk. Let me leave it at that. And one of those ways is what we call cream skimming, which I already mentioned before, is because of adverse selection. We know that people that are ill are going to pick plans with richer benefits because they're going to use them. It's going to be profitable. It's going to be optimal for them. So what they do is in the exchanges, and not in the exchanges, but in general, they're always going to have different products, and the products with higher benefits are going to be priced much, much, much higher. They're going to charge the same to a healthy person as they're going to charge to a not healthy person. Okay, that's under ACA in the exchanges. That's what's going to happen. That's perfectly fine. But if you pick one of the expensive plans, you're going to pay a lot, because they're making the assumption that you are one of those not healthy individuals. Okay, they call it cream skimming. And because we have private insurance, it doesn't mean that private carriers can do anything they want. Hopefully I didn't make it sound like that, because I already told you a few things that may be a little controversial, but not at all. Not at all. Insurance companies, health insurance is extremely heavily regulated at the state level and at the federal level. We have federal and state mandates happening all the time. So most health plans, most health insurance plans, they're probably covered by 40 to 60 mandates. Little rules, little things that modify what do we cover, what we don't, what do we cover, how much we can charge, etc., etc. So they're very heavily regulated. Is how I started my, is that true? Yeah, it is how I started my, yeah, absolutely. It is how I started my career in health insurance with mandates. If you're wondering why I was kind of doubting if that's the reason, it's because I was doing multiple things, but that was one of the main things that I was doing at the time in 2007 was dealing with mandates. With the passage of the Affordable Care Act, one thing that happened is that they created these tiers. We got the bronze, we got the silver, the gold, and the platinum, and each of them is has different benefits, different regulation, what it covers, what it doesn't cover, and at what level. So, for example, the bronze, which is the cheapest, only covers 60% of the actual value. Silver 70, gold 80, and platinum 90. Right. So that platinum will be the richest of all the plans offer under ACA in the exchanges. And in addition to those, there are many other mandates that modify both plans that plans that are offered in the exchanges, as well as plans that are not offered in the exchanges. Other plans, things like guarantee issue, guarantee renewal, restrictions on exclusion on pre-existing conditions, which is still this big thing, but pre-existing conditions have been gone for a long time in many places, Massachusetts being one of them. People are still talking about them as if it's something that's still going on in Massachusetts, but it's really not, and many others. State and federal regulations are the main driver for the increase in health insurance. When you look at your policy, about 50 to 60% of what you're paying is because mandates. And some of let me look at the next slide, because I don't remember if I really forgot about my slide. These mandates are not free. They may sound like great things. Oh, the government now forces insurance companies to cover, whatever. Well, yeah, all the insurance company is going to do is going to turn around and charge you for it. Right? The insurance company cannot pay for it. You're going to pay for it. We are all going to pay for it. So the reason why healthcare is so expensive, drums, is because of government intervention. Governments, the state and federal, have forced insurance companies to add so many benefits and so rich benefits and the cost shares are so low at the same time, that the premiums have gone up significantly because someone has to pay for this. And one, as myself and the author, many other authors, I do believe if we did away with most of these mandates, healthcare will be cheaper, more accessible, and we will probably get rid of most of the uninsured population, of the uninsured in the United States. But this regulation, all it does is it adds cost. Another very interesting topic in health insurance is the idea of group size. We have what we call large versus small or non-group, different ways of calling it. So large groups are over 50 employees, and they face tax penalties if they don't offer healthcare if they don't offer a qualified plan, a plan that qualifies under certain guidelines. So it can't be any plan. And I could tell you a lot of stories about that, and very funny stories involving many years ago, involving electroshock therapy and what it means to have a qualified plan. Is a story there. There's a story there. But they have to offer insurance. Now, under 50 are exempt from offering those qualified plans, but there are other things that they can do, but they're not required to offer the qualified plans. The large group, if they don't, they face significant tax penalties. So if someone that has a job, someone that is employed, if that individual does not have insurance, it's due to either the employer doesn't offer a health plan, probably because it's a small business, or maybe a large business that is going to have to pay the tax penalty. The individual is not eligible as a part-timer as a part-timer because it just doesn't qualify. It only works a couple of hours, or 10 hours, whatever that is. Or the employee just doesn't buy the insurance that is offered by the employer, and that could be for multiple reasons. It could be because it's too expensive, because it just doesn't feel like it, and also very interesting topic is because they get the insurance from their spouses. Their spouses is also is an employee of another company who offers a healthcare plan, and for whatever reason that healthcare plan is better. I'm sure some of you have played this game to figure out which one is better, and they get it through the other. So in an interesting, here's an interesting thing, because it's something that I have worked on a little bit. What's interesting is that companies that offer good healthcare plans, they are actually subsidizing companies that don't offer good plans. What do I mean? If I offer a good health plan, that means that every time a married couple or two domestic partners, whatever that is, every time they face the situation of which health plan are we going to take, yours or mine, which is from my company, which offers a much better plan, they're going to pick the better plan, right? The one that the company is offering. Meaning, the other company, the one that is offering really bad healthcare, is not offering healthcare plans that are as rich. That means that the employees are not going to take that plan because they're going to take the plan from through their spouses from the other account. Therefore, the employer that is offering the lower level care, lower level insurance, does not have to pay the insurance for those individuals. They're happy. If I have if I own my if I have my own company, if I own my own company, and I find out that all my employees, I offer them healthcare, it's just not good, and all of them are going to go with their spouses on their spouse's policy, even better, right? I no longer have to pay for their policies, because remember, the employee is going to pay 20 to 30%. The employer has to pay for 70%. That's savings. So in reality, those accounts that offer better plans are subsidizing those that offer not as good plans, which is pretty interesting. And finally, what is the relationship between insurance and health? Well, they're connected in two places, right? Access and health status. Does a person without insurance, does that person have lower or higher access to care, right? They have a higher access to care because it's usually easier to get into a medical practice, into a medical system if you have good insurance, right? The moment you show that Blue Cross Blue Shield card, you're in, right? If you don't, they probably don't want you there, and then things happen. So you can say that access is restricted to those without insurance. So insurance increases access to care. And then there's health status. Well, would that poor access to care result into poor health outcomes, which we're going to see? You're probably going to say, of course, if you don't have access to care, you get less care, so you have less health status. You have, you're going to have issues. That may or may not be true. We're going to look into that, but in principle, it makes sense, right? But we're going to look at some studies that show some difference, some different opinions. And that's it for chapter 6. Thank you.